get the webinar started. Welcome everyone. My name's Tony Moorhead. I'm a volunteer and a committee member with Haemochromatosis Australia. I have hemochromatosis myself, and I'm starting to feel the effects of arthritis in my hands and knees and feet, so I have a personal interest in the topic tonight. I'd like to begin by acknowledging the traditional owners of the lands on which we meet and extend my respect to their elders past, present and future, and to any First Nations people joining us today. This webinar is a joint effort between Haemochromatosis Australia and Arthritis New South Wales. The event's being held during World Haemochromatosis Week, which provides us and our colleagues around the world an opportunity to focus attention on hemochromatosis and the risks of iron overload. In Australia, we have a series of activities going on, including a concentrated media and social media campaign, the Lighten the Overload campaign, where public assets around the country are lighting up red to mark the week. And I think there's close to 100 around the country at the moment and all over the world, apparently. The Overload Art Exhibition on the Gold Coast University at the Gold Coast University Hospital, and we've kicked off a fun fundraising awareness campaign with a fun event, a virtual balloon race, the race to beat iron overload. And you can find out more about all these activities on our website. So we don't intend to address hemochromatosis specifically today, as I think most people joining us will have been diagnosed with hemochromatosis or they'll have an interest in it already. But we do have a great website, www.h.org.au, with a lot of information and an info line that you can ring, 1300 019 028, for callers during business hours within Australia. And I'll repeat those details later. Today's webinar will be in three parts. First, I'll introduce Kat Keane to talk to us about arthritis itself. Kat's an education officer with Arthritis New South Wales. I'd like to thank Kat for giving us her time today and for her advice and effort getting this webinar ready for this evening. Second, I'll introduce Dr. Graeme Carroll, rheumatologist, academic and researcher based in Perth, to talk to us today about how arthritis interacts with hemochromatosis. And finally, we'll have a question and answer session. So we'll leave questions till then, but you'll be able to submit a question at any time using the Q&A function in the menu at the bottom or top of your Zoom window. If you can't see Q&A, you might need to click on More first and then use the Q&A function to type in a question. We'll do our best to answer as many questions as we can today, and we'll follow up any we don't get a chance to answer. I'll start off so now I'll hand over to Kat. As I've said, Kat's an education officer with Arthritis New South Wales, and she's been a big help to us. She's worked with us in the past in publishing information on arthritis website about hemochromatosis. So without further ado, I'll hand over to Kat.
Thanks, Tony. Okay, just going to set my screen up, so just give me one moment. Okay, like it was mentioned earlier, if you've got some questions, so you don't lose them and you don't forget, please put them in the Q&A box, and if you don't, there is just the chat box, but the Q&A box is best for that. And so we'll try to get to those, or as many as we can afterwards. So my role here tonight is to talk about arthritis briefly, but mainly my focus is to address and talk about how to manage arthritis. So without further ado, I'll just jump straight in. What is arthritis? And the self-management practices being exercise, diet, and how to manage pain. Because no matter what arthritis you have, the number one complained about symptom is pain. So just very quickly, arthritis is a very common condition, but it's actually not well understood. And arthritis itself, the word, is not called as such. It's not a single disease. In fact, it's just an informal way to say or refer to joint disease or joint pain. There are over 100 different types of arthritis, all with different causes, including general aging, too much or too little load over time, injuries. There are metabolic drivers to infections. There are underlying diseases such as autoimmune conditions, and of course, hemochromatosis. People of all ages, sexes, races can and do have arthritis. In Australia, it is one of the leading cause of disability, with 1 in 7 adults having arthritis and 1 in 1,000 children also suffering from a form of arthritis. It's more common in women and occurs more frequently as people age. Common arthritis symptoms or joint symptoms include swelling, pain, stiffness, decreased range of motion at the very least. Symptoms may come and go. They can be mild, moderate, or severe, and they may stay about the same for years and then can progress or get worse over time. We've also got arthritis causing permanent joint changes, which can significantly affect quality of life. Again, very briefly, looking at what arthritis is, well, first of all, we need to understand the function, or should I say the structure of a joint. So very, very briefly, arthritis affects mainly the articular cartilage. So this blue line here, this is the cartilage that covers the ends of long bones. It causes or creates a smooth surface to allow bones to slide past each other easily while moving. Cartilage also helps absorb shock and distributes load or pressure as we move. Cartilage doesn't have a nerve supply or a blood supply, which is why it is so important to move. Moving nourishes cartilage. Cartilage is nourished through moving and taking weight through the joint, for example, walking. Now, the middle illustration here is an example of osteoarthritis. Like I said, remember, there are over 100 different types, and we're going to have a look at a few of those in a minute. This is one type. This is osteoarthritis. And over time, the cartilage is worn away. It's progressive as it degenerates. There is also this growth of bone or spurs as well. And you can see a slight bit of deforming happening here as well. The integrity of the bone is also compromised. Then we move to rheumatoid arthritis, which is an autoimmune inflammatory condition. And it affects the joint and the cartilage in similar ways as osteoarthritis, but the main difference here being is that it causes a whole lot of inflammation, more than osteoarthritis, in that the areas around the joint, so the tissues that are surrounding the joint capsule and the synovial fluid can become inflamed. And over time, as these flares occur, as these inflammatory flares occur, as the body attacks those tissues, they can again become deformed. The cartilage, obviously in this picture here, is nowhere to be seen. The bone is severely affected as well. So just a very quick snapshot of what arthritis is and what it does to cartilage. I thought this might be interesting to you all because there are over 100 different types of arthritis. And here in that first column, I have an example of osteoarthritis, rheumatoid arthritis, and gout, which are the most common forms of arthritis. We also have less common forms like ankylosing spondylitis, psoriatic arthritis, juvenile idiopathic arthritis, and then of course there is arthritis that is due to hemochromatosis. So these are the types. Now, those are caused by different mechanisms. So this is the green or the middle line here. With arthritis, The mechanism behind the wearing of the cartilage is often due to just general age, just like you would get wrinkles or grey hair, load, and also metabolic issues as well, such as fatty lipids and glucose as well. They can severely affect cartilage. We also have rheumatoid arthritis being an inflammatory autoimmune condition, so the body attacks tissues. We have gout, which again is metabolic, so that's to do with uric acid buildup in the body. And then, of course, the mechanism behind arthritis due to hemochromatosis is iron overload. And these all of these, nearly every form of arthritis has the same or similar phenotype, meaning an observable characteristic or trait. They all cause cartilage degeneration, subchondral or bone destruction, and synovitis. In most cases, synovitis. So that's inflammation of the synovial fluid. So I thought that was quite interesting to note. Now, just because there's the same outcome, so the same phenotype and same symptoms, or very similar, it doesn't mean that the treatment is always the same. So for example, there are different drugs or medical procedures to help reduce or suppress the mechanism of arthritis. For example, our autoimmune system. For example, venesection for those with hemochromatosis. However, broadly speaking, there are two things that you can focus on that will help you manage your arthritis, and these are exercise and nutrition. So let's jump into those right now. So exercise, how much should you do? That's a good question, one I get asked a lot. And the best that you can do, or what you should or can aim for, is around 150 minutes of some form of exercise. This mainly being aerobic activity, moderate intensity, per week. And it doesn't matter how you do this or how you chunk your time. So you could do half an hour every day, for example, and you chunk it up into 10-minute bouts. It is achievable, but it's just about how you do it. You, of course, can do less time per week, but you need to be, the intensity needs to increase. So this is the type of exercise where you have a lot of trouble talking while you're exercising, high ventilation rate, high heart rate, and sweating. Of course, you can do a combination of both intensities. Now, just as an example, aerobic activity could be, walking, for example, running, swimming, or riding a bike. But exercise for arthritis needs to include strength training, and strength training at least twice a week. But the bottom line is some physical activity is better than none. So, well, you ask me, what should I do? Well, we have aerobic that we just mentioned. So you might need to consider the impact. So you might need to look at high or low impact activities and their pros and cons when it comes to aerobic activity. So low impact aerobic activities don't put as much stress on the joints, which might be a good thing, because you might be in a flare state. It might be very painful at that moment. You might have reduced range of motion. And so doing some low impact exercise like walking, like cycling or swimming might be good for you. If you can handle a little bit more, then you can increase your intensity, and you can also increase the impact as well. So doing more things that might include some form of a jump, like running, like going up and down stairs. Must include strength training. So either it being weight bearing or it being with weights or some form of resistance, like a resistance or TheraBand. So lifting weights, working with bands, doing yoga and Pilates. You can do exercises at home, at a gym, or in the park, or with friends. You can quite literally do that one anywhere. Flexibility and balance are also really important, so that we promote and we maintain our range of motion and our proprioception, which is also really great for falls prevention. So they're also very, very important. Tai Chi is fantastic for those people with arthritis. Specifically speaking, a lot of the research done for Tai Chi is for those with osteoarthritis of the knee and the hip. But generally speaking, you can somewhat generalize that because it is a nice, gentle exercise. You move through motion quite slowly. And there's also balance involved as well. And flexibility. So ensuring that we take our body through ranges of motion through general static stretches or more dynamic ones. So moving through a range of motion. And again, this can be achieved through Tai Chi, through yoga, and or through Pilates. The benefits of exercise, well, there are many, and I won't go through all of them, but the main one being that it nourishes cartilage and bone. And again, depending on the mechanism of the condition, cartilage or exercise has been known to actually stimulate stalled or reduced regenerative processes and actually help improve joint cartilage composition. Now, I'm not sure if that's applicable or can be generalized to arthritis caused by hemochromatosis, and Graeme might be able to enlighten us later about that. But other forms of arthritis, it certainly is the case. Exercise is safe. It does not harm the joint. And of course, joints with arthritis benefit from exercise so long as it's done with consideration and in moderation, of course. We used to think that arthritis is this wear and tear type of disease, but in fact, what I want you to start thinking is wear and repair, okay? It keeps our muscles strong, it can control our weight, reduce pain and stiffness, and generally increase a feeling of well-being. I want you to think motion is lotion. So with that exercise, nourishing the cartilage. So exercise moves synovial fluid around, and that synovial fluid nourishes. The synovial fluid is basically nerve supply and the blood supply to cartilage. So I want you to think of Tin Man from Wizard of Oz. I want you to think of the oil going into his joints. I want you to think of that motion is lotion, okay? Exercise is very important to feed your cartilage. Okay, if you don't know where to go, just very quickly, check out our Get Moving and Get Moving Plus. We have booklets and videos to go along with this. So very, very basic, starting off doing exercises for nearly all body parts in a chair, all the way through to beginner, intermediate, and advanced. And this is general exercise, so full body. Then if you're wanting something a little bit more specific, we do have Get Moving Plus, and it focuses on specific exercises for each joint. So we've got spine, we've got shoulder, hand, we've got hip, knee, and ankle, and I said spine. Yes. So have a check of those ones out. They're PDFs and videos. They're on our website. Now, what about diet, you say? Consider diet and nutrition from two perspectives. One is weight. So one is weight, and the second is inflammation. So when it comes to weight, we consider in our diet what we eat, so the quality, and how much we eat. So let's start thinking everything in moderation, because making just a few changes here and there to what we eat and how much we eat, together with exercise, of course, can help us lose weight. Losing as little as 5% of your body weight, this is, of course, if you are overweight, can significantly reduce pain and disability symptoms of arthritis. So taking weight or excess weight off joints can make a huge difference, particularly over time. The second consideration is inflammation. So what we think about, this is what we think about the nutritional content of the food we're putting into our bodies. And does this contribute to a net inflammatory or anti-inflammatory or inflammatory state? Okay, so we want to go for anti-inflammatory states. Those that have polyphenols and those who have, for example, antioxidants and good fats, good fatty acids, omega-3s, etc. So that leads me then, is there a specific diet for arthritis? Well, the answer is kind of always no, but we could certainly lean towards one, and that's the Mediterranean diet. And the research has been done with those people with chronic illnesses like diabetes, heart disease, obesity, also those with arthritis. And the research points towards the Mediterranean diet as helpful, significantly helpful for all of those chronic illnesses. And it can be generalized to many, if not all populations. It has a variety of food. It isn't restrictive. It's certainly sustainable. And so it just ticks all the boxes of a diet to follow. The best thing about the Mediterranean diet is that it includes red wine and chocolate, which is always a plus for myself. It pulls from a lot of this beautiful fresh produce, okay? And instead of weighing in on a lot of poultry and red meat, as maybe the Australian dietary guideline does a little bit more so, this one weighs in a little bit more on fish and seafood to get the protein, okay? So that's also really important. And like I said, it's anti-inflammatory. So it has really good omega-3, like all fats. It has polyphenols, and it has the antioxidants of all those beautiful fresh fruits, nuts, and vegetables. So the foods that we want to avoid, because these may lead to inflammation or weight gain, these are your highly, highly refined and processed foods, like refined carbohydrates and white breads, etc. Chips, soft drink, processed meats. They're all the fun foods. Now, you don't have to eliminate them completely, but it's about minimizing them and having them in moderation. And just finally, a few tips on when it comes to food, just considering what we're eating and the plate size. So the plate here is a really good example of how you might like to distribute your vegetables, starch, carbs, and proteins. Try to go for smaller plates, maybe more meals throughout the day. The 2 fruit and 5 veg is still a thing. And there are a few other ways in which we could manage pain. And this will be my final slide for tonight. So we have topical creams for relief. Capsaicin cream is recommended. The efficacy of it is good. Physio cream, Voltaren, and Tiger Balm. Also adding heat or cold can also help. And I liken this to, if you bump your elbow on your funny bone, what do you normally do to make that pain go away? Well, I'll answer it for you because you can't. When you bump it, you rub it. And rubbing it creates a distraction. And basically that feeling that you get from rubbing, that friction, fight the pain messages to our brain. So adding something like a topical cream, heat, adding something like, a heat pack, water bottle, whatever it is, actually competes with that pain stimulus, hence why it reduces pain. We also have distraction, socializing and finding meaning in daily activities. Cognitive behavioral therapy or ACT can also really help from that cognitive point of view, so our feelings and our thoughts about pain and how we manage that. Cannabidiol is particularly the non-psychoactive component, may be found, depending on where you are in the world, has some great research done behind it at the moment. That can also help with pain, particularly chronic pain. Addressing sleep issues. If we sleep better, we can handle pain better and it will reduce the level of pain. And pacing our activities. So chunking tasks and taking frequent breaks. Okay, I'm now finished. I'll wrap that up and I will stop my share and pass you back to Tony, who will introduce you or get you going with Graeme. Thank you, everyone.
Thanks, Kat. That was very informative. I'm sure we'll get a few questions at the end or as we're going. I'll hand over to Graeme next. Graeme's a rheumatologist working in private practice. He's a member of the Faculty of Medicine at Notre Dame University Fremantle campus, a researcher who's published over 80 publications, and a medical advisor to Haemochromatosis Australia. Graeme has worked closely with Haemochromatosis Australia in the past, speaking at conferences and public information sessions in Perth, presenting one of our Iron Matters podcasts, and we try and help with research projects that Graeme's involved in. Over to you.
I'll begin by talking a little bit about hemochromatosis itself, and one very simplistic way of thinking about it is in terms of there being an imbalance between iron that we obtain through various pathways and iron that we eliminate through various pathways. If there is an imbalance, then there is potential for either deficiency or excess. And in hemochromatosis, of course, it is a significant excess. Next slide, Tony, thanks.
Okay.
Most of the consequences of iron overload are amenable to at least partial limitation, if not prevention. And that's well seen in terms of the control of or reversal of symptoms like fatigue, damage to the liver, damage to the skin, hormonal effects and consequences. In many ways, the correction of that iron imbalance pays off. In terms of the bones and joints, it's far less clear, but experience amongst those who have obvious involvement of the joints suggests that if there is some benefit, it's limited. And the jury is really still out as to whether or not there is benefit or not, but the general consensus is that there's probably not very much benefit. So here we have a different situation, unlike other organs in the body where elimination of iron or correction of that imbalance pays off in terms of significant improvement in symptoms and in terms of what happens to the organs affected. We don't see that, not clearly at least anyway, in bones or joints. Thanks, Tony.
Great.
I'll just go through a little of what we know about how bones and joints are affected in hereditary hemochromatosis. About 1 in 4 individuals will have some significant joint disease. That's in terms of that which can be appreciated on an examination or through an examination and through imaging of one kind or another. We don't really know the exact number in whom there are significant symptoms, but perhaps not any evidence of damage to the joints, either clinically obvious or in terms of imaging studies, but it's probably higher. And it's less clear as well as to the effect on the skeleton or bones in general, but somewhere between 1 in 5 and maybe as high as 1 in 3 will be susceptible to loss of bone, giving rise to what we refer to as osteoporosis. That loss of bone makes the bone more vulnerable to fracture, and so there can be significant consequences in terms of the performance of the bones in supporting the body. The symptoms of joint disease may be the first symptoms, may occur at the same time as the diagnosis becomes apparent, or in some cases will appear later. This timing doesn't seem to have a clear pattern. Joints in the hands, hips and ankles are most frequently involved, but there may be involvement of other joints like knees, elbows, shoulders, and spinal joints as well. And the features vary, but they may be considered to be more like those of osteoarthritis than inflammatory joint diseases such as gout and rheumatoid arthritis, for example. Rarely, a mimic of gout known as pseudo-gout may occur in hereditary hemochromatosis. But for the most part, what we see in the joints seems to mostly resemble what is seen in osteoarthritis, which is the most common type of arthritis occurring predominantly in people aged 50 and above, and affecting the same kind of joints for the most part. And progression to advanced joint disease, such as to require joint surgery, usually takes decades rather than years, for example, the surgery that is required, say for a hip replacement, for example, or a replacement or fusion of an ankle, is usually required after the age of 50, often with very good results. So there doesn't seem to be anything about hemochromatosis that makes you less likely to get a good outcome from surgical intervention. There used to be a time when there was a lot of enthusiasm for surgery in the hands to try and replace joints like the knuckle joints, for example, at the base of the fingers. And that's become less popular in recent times because the results aren't nearly as good as those for big joints like hips and knees, even shoulders and ankles. Unfortunately, those hand joints are commonly affected in hemochromatosis, so that leaves us with unsatisfactory long-term options in that setting. And next slide. Physicians, GPs, persons affected and others often wonder about whether this is an inflammatory type of arthritis. It's been difficult to resolve that issue. Sometimes the joints will appear to be very inflamed. They will be quite swollen, very tender, painful to move. There will maybe be some heat appreciated in them as well. Not often is there redness. When tissue is available for analysis, the tissue obtained from persons with hemochromatosis seems to lie between that of rheumatoid arthritis and osteoarthritis. So it's more inflamed than it is in osteoarthritis, but less inflamed than it is in rheumatoid arthritis. Almost certainly the processes in all three of these conditions are quite different, but we don't understand how so and what that means. If there is any fluid in a joint that can be retrieved and analysed, there's rarely much of an inflammatory response in the fluid. It has quite low numbers of white blood cells, like a normal fluid or like a fluid obtained from a person with osteoarthritis. So overall, it's fair to say that it's not terribly inflammatory, and that tends to agree with the observations that are made when various types of anti-inflammatory therapies are offered. So the standard approach that might be taken for a very aggressive inflammatory disease like rheumatoid arthritis doesn't work out very well in hemochromatosis. We don't see the sorts of responses that rheumatoid patients obtain. And it doesn't seem to matter which treatments are tried, the result is consistent across the board. In general, there's not much of a response. It's true to say that there's not much of a response in osteoarthritis either, and everyone is well aware of that, and there's no surprises there. But there was a feeling that because hemochromatotic arthropathy was a little bit more inflammatory, there might be a greater dividend from use of aggressive anti-inflammatory therapy, but that hasn't turned out to be the case. That's not to say that treatments that are directed to some extent at controlling inflammatory activity don't have a place. They certainly do have a place, but the returns are not great. So if it is safe to use an oral anti-inflammatory agent like Mobic, for example, or naproxen, and that will be the case some of the time, that might well be quite useful. Not dramatic as a rule, but quite useful, certainly in some. And topical agents that suppress inflammatory reactions can also be quite helpful for a particular joint, especially in situations where that treatment can be readily applied. So spinal joints, not easy because they're deep and not that accessible, but a knee, for example, or an ankle, for example, or small joints in the hands are certainly joints that are amenable to treatment with topical agents, both over-the-counter ones and also prescription ones. Compounding pharmacists can make up a cocktail of various agents that can be particularly useful for small joints. And next slide. Why is it that joints are more vulnerable to damage in this disorder than is the case for other organs? Unfortunately, still the answer isn't known. And why some joints are more severely affected than others is also unclear. It's possible that the different anatomy in these joints is relevant. It's possible that differences in blood supply are relevant, and the mechanisms for clearance of iron may be different as well. One possibility is that, unlike in other organs, where in general blood supply is very good, in the deeper tissues in joints, like the cartilage and bone that are quite vulnerable to damage, there may not be enough blood supply to allow for iron to be retrieved, if you like, once it becomes deposited. The lining tissue of the joint may react to iron accumulation in the joint space in an effort to clear the iron, but it's quite possible that that's an ineffective reaction. It doesn't achieve its goal. It doesn't remove the iron effectively from the joint. And so you have what is, in a sense, a kind of trapping or retention of iron in the joint that over time might accumulate to the point where it becomes really very counterproductive, and there's collateral damage in terms of the cartilage or the joint surface being eroded, and the joint process of decay follows or ensues. Over a long period of time, the bearing surface of the joint may erode in the face of this continuing onslaught, the consequences of which are likely to be permanent or irreversible. Thus, the key to prevention of joint damage in hemochromatosis may lie in overcoming the iron trapping, if you like, in the joint. And that may be a focus of further research and possibly will yield results in time if in fact that theory or hypothesis is in fact correct. And next slide. These are just a couple of the examples I've included of joints that are affected and damaged in patients with hemochromatosis. The top two images are those of the hip, or a hip that has been quite severely affected. The joint space is lost and there are large cystic structures beneath that joint surface, shown as a grey on the left in panel A and as a white on the right in panel B. That kind of reaction in the bone is seen when the cartilage is no longer able to do its job. There's just no satisfactory cushion, if you like, and so the bone is overloaded as a result of that lack of good cushioning, and it then begins to break down and react in various abnormal ways that compounds matters. A lot of the pain that is experienced in a late stage of hip arthritis is probably because of this process in the bone. In the lower half of the slide, I've just shown two hands. That on the left is a normal hand. You can see that the fingers will close tightly into a fist. You can't see the fingernails at all. In contrast, on the right, in particular, the index and middle fingers fail to close properly. The ring finger, to a lesser extent, you can see the nails much more easily, and the index and middle finger ride high, if you like, in comparison to the normal hand on the left-hand side. This is referred to as an iron fist sign. It's seen in quite a high proportion of individuals with hemochromatosis in whom the joints are significantly involved. It's also seen in some patients with osteoarthritis, and so it's by no means specific. What it indicates is that there has been damage to the knuckle joints, or what we call the MCP joints at the base of the fingers. X-rays in that setting will often show characteristic features that are seen in hemochromatosis and are helpful in terms of estimating the likelihood that the damage that has occurred in those joints is of hemochromatotic origin as opposed to some other cause. Next slide. We're interested in what drives the damage or promotes the damage, causes it or leads to it. One question that arises is it really the iron load at all that is responsible? There could, for example, be other causes, including the possibility that genes that might also be inherited with the defective HFE gene could be responsible. And so in the last few years, we've been looking at this question and trying to determine whether it may be the iron load after all that is relevant, or whether there is not very much support for that possibility. In the panel at the bottom of the slide, on the left-hand side, you can see a group of red blood cells. These can be relatively easily measured with appropriate equipment in terms of their size. And one parameter that is often provided when there is a report on a full blood picture is the volume of those red blood cells. It's referred to as the MCV. We looked at that MCV in a range of patients with arthritis and noted that those who had hemochromatosis and arthritis in the far left of the right-hand panel, or right-hand part of that panel, had high MCVs, implying larger red blood cells, than did the group who had no arthritis, seen in the second column. We compared these patients with others who had other types of arthritis, osteoarthritis, for example, rheumatoid arthritis, and some osteoarthritis patients who had a pattern of joint involvement that was more like that of hemochromatosis. And there was not any increase in the MCV in those individuals. So it would seem that there is support from this kind of analysis for a relationship between the MCV, high MCV in particular, correlating with the presence of arthritis in individuals who have hemochromatosis. Now, that doesn't mean cause and effect, of course, but what it does indicate is that there is likely to be support from this type of study for the iron load playing a part, since the higher the iron load, the more likely it is for the red blood cells to increase in size. That's a phenomenon that is seen as a result of the new red blood cells coming out of the bone marrow being influenced by the iron and having larger dimensions. And next slide. So just to recap on that and to show this with some arrows that highlight more satisfactorily for you the groups in question, the red arrow points to the high MCV in the patients with hemochromatosis who had arthritis. And the top blue arrow points to those with no arthritis. And the bottom blue arrow points to patients who did not have hemochromatosis but had a form of osteoarthritis. And next slide, thank you. Over the past 15 years, those patients that I've encountered with hemochromatosis and arthritis have had imaging done that allowed us to create a score, which we referred to as the joint damage score. So all joints that were affected were included, and the extent or the severity of the arthritis in those joints was graded, and we came to a total score for every individual. And we then looked at the iron load in those individuals at the time of diagnosis, or the earliest time point at which we could obtain some data, and then correlated the findings. And you can see for the ferritin, the biochemical measure of iron load, an iron storage protein that gives us an indication thereof, in the top panel, that there was a relationship between the amount of damage and the ferritin concentration at diagnosis. In the lower panel, we also looked at MCV once again. So this was looking at MCV in a different way. Instead of just categorizing patients arthritis or no arthritis, here we were able to look at how severe that arthritis was and correlate it with the MCV. In both, there was a relationship, moderately strong, statistically significant, consistent with there being a real relationship between the amount of joint damage and the iron load at the time of diagnosis or as early as possible in the care of those patients. So this too adds to the same story in respect to there being some relationship at least between the iron load and the development of the arthritis and its severity over time. Next slide, thanks, Tony. And here I've just put in an arrow to identify those patients who had quite high ferritin concentrations. And you can see that they're at the right-hand end of the spectrum of joint damage here. And the same was true for MCV. There's a fair bit of scatter. It's not a highly consistent relationship, but there's a lot of variables here that can confound the analysis. Not being able to get the ferritin at the exact time of diagnosis in quite a few patients, not being able to have a systematic approach to assessment of the joints. Only those that were sufficiently symptomatic to warrant x-rays had imaging done, and so it's quite likely that some joints in which there was significant arthritis would have been missed. So there are lots of factors that make it difficult to get a tight relationship in such a study. But what we have at least is reasonably supportive of the notion that iron load is a major contributor to the development of joint damage over time. And next slide, thanks. So to summarise, the relationship between red blood cell size and the X-ray evidence for joint damage in hemochromatosis aligns with the findings for iron storage protein or ferritin and X-ray evidence for joint damage. Collectively, these two strands of evidence, if you like, strengthen the argument for iron load as a key contributor to the development of arthritis, as opposed to genes independent of iron metabolism, for example. If these findings are confirmed in larger studies conducted in more diverse populations of patients, it will prompt a shift in focus toward earlier identification of iron load and more intensive investigation of strategies to remove iron, including possibly the use of medicines known as iron chelators, which are already used for other blood disorders such as thalassemia to protect against organ damage. So to just add a little to that, the strategy over time to date has been to remove as much iron as possible in the interest of minimizing damage in all of the organs, but we've seen less benefit in joints and potentially bones than one might have expected. This suggests that there is some other mechanism at play in the joints that may be related to trapping of iron or retention of iron, persistence of iron in the joints themselves. Why that might occur, we still don't know. How to address it, therefore, is difficult, but there may be scope to remove that iron through alternative strategies that we haven't really explored in depth as yet, and that may eventually pay off in terms of preserving the joints more satisfactorily, minimizing the damage, and hopefully improving symptoms and deferring the need for surgery. I'll leave it there. Happy to answer any questions now or later.
Okay, I'll stop the presentation and we'll move on to some questions. We are a bit over time, but we will keep going for a while. If you do have to leave, then perhaps you can catch up on the recording later, but I hope you'll stick around. Okay, I'll put up some questions. Okay. I'll just read a few out and suggest who might answer them. Hello all. No families have hemochromatosis, but after a hernia operation, I found out I have it. I had to scream at my GP to do blood tests for me. I have pain in my joints. I knew something was wrong, and I've never seen a GP in 20 years before the operation. Is that common? Well, the short answer is yes. It's quite common for people to be the first person diagnosed or detected with hemochromatosis in a family. Because it is genetic, it's very unlikely that you would be the first person to actually have hemochromatosis. It's just that it's being picked up more often these days because we're more aware of it. We now have a gene test. But yes, it's quite often that people don't have a clue they've got hemochromatosis until a doctor says you've got it. How valuable is glucosamine in helping repair damage in joints? Graeme or Kat? Graeme?
I doubt that it is that helpful. I think that there was a lot of enthusiasm for it in earlier times when there was a body of evidence, let's say, that was suggesting that it could have major beneficial effects. But I think over time, firstly, the science hasn't held up. Secondly, the experience hasn't held up. And I think over time to come, it's unlikely that we will see evidence emerging that really strongly supports it as a medication or an agent that can truly restore cartilage that's been damaged.
Yeah, I agree. We often get asked those questions. And is it chondroitin as well?
Yes.
Many other supplements from the complementary and alternative medicines, traditional Chinese medicines that particularly the westernized studies as well, or probably around the world. Yeah, you're right. They just don't hold up. The evidence is quite mixed as well. And some say that it helps with pain, but then is it actually helping at a structural level? Again, not sure. The RACGP don't recommend, so that's the Royal Australian College of General Practitioners, for those who weren't sure. They don't recommend offering it, prescribing it to their patients. Look, it's pretty harmless, the same with chondroitin as well. It's fairly safe. If you have the money and the time, you can certainly give it a go, but I think it's that old saying, it's just can be expensive. People say that with when it comes to those sorts of things. So you can give it a crack, but probably, yeah, the evidence doesn't hold up.
Okay, thanks, Graeme and Kat. the next question was, I was told that once my ferritin levels were back to normal, after numerous venesections, and my original ferritin level was 1325, no further deterioration due to osteoarthritis would occur, yet I've had 2 hip replacements and a big toe joint fusion since my ferritin level went back to normal. Well, I think Graeme's addressed that already in his presentation, but did you want to add anything to that, Graeme?
No, not really.
Okay, yeah. Okay, this is more of a hemochromatosis questions, I think. What seafood do we need to avoid, limit when we have hemochromatosis? Well, the answer probably is raw shellfish. Cooked shellfish are fine because there's a particular bacteria that can live in shellfish that thrives on iron, but it's fairly uncommon in Australia for people to have problems from consuming shellfish, even people with hemochromatosis. If your iron levels are normal, you shouldn't have a problem. Most seafood that's harvested in Australia is actually tested for that bacteria, so it's eliminated. Possibly you could find it in some imported shellfish, so if you want to be really, really careful, you can avoid eating imported oysters and prawns, but to be honest, you're much more likely to get Vibrio vulcaniferous, I think it's called, from wading in seawater if you've got a graze on your leg than you are from eating shellfish. Question for Kat. If I only have arthritis in my hands so far at 69-year-old and actively walk, etc., how important is weight or strengthening exercise? Again, I think you've talked about that, Kat, but do you want to add anything?
Yeah, look, I think that person's saying, I've got it in my hands, but not anywhere else. Like, why is it important, or how important is it? Well, I know no one's really doing push-ups with their fingers. I understand that. But for overall health, to maintain your health and to maintain the integrity of your bones and the joints and all the other lovely inert tissues that surround it and protect it, it is very, very important. I can't stress that enough. If you are looking for explicit exercises for the hands, wrists, and the fingers, that do include using putty, so for strengthening, and rubber bands, again for strengthening. You can find the Get Moving Plus Hand PDF on our website, which will be quite helpful. So specifically to the joint, it's very important, though it looks different to walking or doing squats or something like that. It looks different to finger or hand exercises, but all in all, in general, exercise and strength-based training is so important.
Okay, possibly one for Graeme. Just to clarify, anti-inflammatory medications are not that effective in arthritis caused by by hemochromatosis. I think you've addressed that already too, Graeme.
Yeah, I know. It's been really difficult to find any treatments that have high impact on this type of arthritis. I don't think that we are able to say that anti-inflammatories just never work for anybody. I think it's quite variable. They can be helpful for some. And my experience is that both oral and topical agents do work for some.
Okay. Another question, ferritin or MCV at diagnosis against joint damage would also be dependent on age at diagnosis? Question mark. So I guess that's...
I think that's a fair point, in the sense that those who are not diagnosed early present, or in whom the diagnosis is made at a much later date than one would like, will have higher concentrations, and that likely will impact whether or not they develop more arthritis or not.
Okay, my ferritin was 1,050 at diagnosis and my MCV was 99. I'm wondering what that tells me.
I think all we can say is that in general, the higher these values are, the greater is the risk. But it's also fair to say that there are good exceptions in that collection of data that we have. So I think all that one can say is there's a correlation. It would appear that you're running a higher risk. It's a little bit like a cholesterol being higher and you having a higher risk of heart disease. It doesn't follow. It isn't necessarily the case that there will be those consequences. They're merely pointers.
Okay. Well, I'm not quite sure I understand this one. Can hemochromatosis contribute to spontaneous osteonecrosis of the joints, particularly the knee?
I think the answer is yes, but it's rare.
Okay. I've heard that arthritis can get worse after treatment. Could this possibly be because you are regularly removing blood that you say is necessary to remove iron build up in the joints? Does that make sense? I've heard that arthritis can get worse after treatment, which I guess is venesection. Could this possibly be because you are regularly removing blood that you say is necessary to remove iron build up in the joints?
Yeah, I don't know that it's commonplace for arthritis to get worse after treatment is commenced. And if you look at what is reported by patients in regard to their joints, so that subgroup that do have arthritis, 1/3 says it's worse, 1/3 says it's better, and the other third says there's no change. Almost in all areas of medicine, when you get that kind of feedback, it means there's probably nothing going on here. Now, there may be other factors going on that might lead to joints being more uncomfortable, and that's, you know, if just venesection is implemented and nothing else, there may be difficulty in explaining that. In general, I don't think the overall picture supports the idea that it consistently gets worse. And in terms of what a mechanism would be to explain that, I agree. It seems paradoxical that there should be a worsening. Having said that, I have real doubts about whether or not you alter the amount of iron in the joint with venesection at all. And what concerns me is that we have just not been able to address that issue, because unlike blood tests where the blood is easily accessible, it's not so easy to draw some fluid from a joint when there isn't a therapeutic objective, merely in order to find out what's happening to the iron concentrations in the joint. Be a fascinating study to look at what happens to iron concentrations in the joint fluid if it were feasible in some patients, but it's been very difficult to do that.
Okay, thanks. Is there a correlation between hemochromatosis and gout?
I think the evidence suggests that gout is a bit less common in hemochromatosis.
Oh, some good news.
I'm not certain about that.
Can you get hemochromatotic arthritis if you don't have high iron or ferritin levels? Ooh.
No.
Those studies that I did and where we looked at joint damage and the concentrations of iron were imperfect in the sense that the relationship was not so strong that you could say that if the concentration of iron or the MCV was below certain levels, then you were safe and you would never get it. So I think the answer is no.
Okay. Besides CBC, which is a blood count, I guess,
Yes.
and ferritin blood test, are there other blood tests that are useful to follow progress of the arthritis due to hemochromatosis?
I don't think there are.
Okay. We're trying to fly. So we're getting towards the end of these questions. So what is the latest recommendation as to the optimum ferritin level for a hemochromatosis person? I was advised to keep mine at 50, but certainly less than 100. Well, I can probably answer that. That is the international therapeutic guidelines. Of course, that does come with proviso that all other things being equal, try and keep it between 50 and 100 once you have been diagnosed with genetic hemochromatosis. There can be other factors. It is sometimes a cost-benefit sort of analysis, whether venesecting someone aggressively to get their ferritin levels right down may have other effects, like, you know, things like age and your general health and other factors the doctor might need to take into account. But normally that is the recommended levels, 50 to 100. So I'm not sure this question is within the scope of the webinar. What is the effect of iron overload on the immune system? I don't feel qualified to answer that, except that hemochromatosis is not an immune system condition or disease.
Indeed, and I don't think we've really seen or observed any significant effects, so that there doesn't seem to be any immunodeficiency or lack of immune function such that individuals don't respond to vaccines or are far more susceptible to infections, for example. So I think there probably isn't a major effect.
Yeah,
I know of none.
Yeah, I'd agree. That's my observations. And the final question: I'm finding it very hard to find a GP who has an understanding of hemochromatosis and my pain. Who should I ask for a referral to investigate my pain? I guess that's pain due to arthritis. So, Graeme.
Yeah, I think it's certainly worth considering involvement of people outside the sphere of arthritis in respect to pain. So there might be value in seeing a pain medicine specialist, for example. There might be value in seeing physiotherapists interested in pain, for example. But first up, maybe if it is clearly related to the joints, or most of the pain seems to be musculoskeletal, then I think seeing a rheumatologist and determining whether or not they have something that they can offer, or they can give advice in respect to directions in which you may go for assistance from others, would be a reasonable way to go.
Okay, thank you. Well, another one, a couple more have sneaked in. It would just see if we can get through these very quickly. If I have symptoms of hemochromatosis, is it more likely I'm experiencing pseudo-gout or gout? And are treatments the same?
It's more likely it's neither. Gout is usually fairly easily recognised, and pseudo-gout similarly. I would think if there are concerns in that regard, it can't be easily resolved through a GP or any other person available to advise in regard to it, then again, it sounds complex enough to warrant a rheumatologist's opinion.
Okay. And final question, and we will make this the last one. Any new treatment for hemochromatosis on the horizon instead of venesection? Well, from my knowledge, there is a lot of research going on at the moment into alternative treatments. There's actually some clinical trials have started. If you're in Melbourne, you could look up Nucleus Network's website. They're doing a clinical trial at the moment on different types of treatments, like a range of things. But the message we get from all of the experts is that even if And some of them look fairly promising. Even if they do occur, it's still going to be quite some time before we see any sort of commercial or widely available alternative treatments. Venesection, I know nobody likes needles. I don't like needles, and I've had a lot of them. But it is simple, it's effective, it's cheap, and to be very honest, I would rather have the venesection every 3 months than take pills every day, but that's my personal opinion. I know some people do have difficulty with venesection, and that can be a real issue for people. But at the moment, I don't think I think alternatives are years away still. Do you have anything to add, Graeme?
No, I don't really. I don't know a great deal about that aspect of the research and clinical studies at the present time. But in talking to colleagues, there have been possibilities under consideration, including under the skin injections as well.
Yeah. Thanks everyone for joining us today. Thanks Kat and Graeme for your excellent presentations and for answering some tricky questions. Thanks to Arthritis New South Wales for sharing this webinar with Haemochromatosis Australia.
Welcome.